Good morning. This is MRSA as a staph bacterium. MRSA, or methicillin-resistant Staphylococcus aureus, is a gram-positive, spherically shaped bacilli. The first culture to be methicillin-resistant was identified on October the 2nd in 1960 in London. MRSA typically causes skin or soft tissue infections, and it continues to be relevant in the medical field due to its resistance to antibiotics and the frequency with which infections occur. MRSA was originally only found in healthcare settings, so it was called hospital-acquired methicillin-resistant Staphylococcus aureus, but now it can be found out in the community as well. This infection spreads through contact with infected persons' sores or wounds and can be spread through respiratory droplets from cough or speech as well. MRSA can live on the skin of otherwise healthy individuals with no symptoms indefinitely. It can live for up to 8 weeks on a mop head, 9 weeks on a cotton towel, up to 203 days on a blanket, and it can live for up to 7 months on dust. So this is something that you would come into contact with in some shape, form, or fashion in the environment. A clinical scenario. A patient comes into the clinic complaining of a swollen and inflamed wound site leaking a pus-like fluid. As we just saw in the previous slide, MRSA can live for extended periods of time on inanimate surfaces or objects, so bacteria transfer is relatively easy to occur. And as such, any open wounds on the bodies, think, razor nicks or, any kind of opening in that protective layer of skin would allow the MRSA bacterium entry into the body. Then it can cause an infection. As a transient microbiota, it can cause a lot of problems. But it is a normal occurring bacteria microbiota on the skin surface. Clinical situations for MRSA occur at opposite ends of the spectrum. Either it is a simple situation like this, or you have such an advanced case of MRSA that the patient may present as borderline septic. On the simpler side of things, MRSA will present as an abscess in someone's skin, as a red, inflamed, pus-filled cyst, or a wound that will not heal. We cannot know if it is MRSA until it is submitted for lab cultures. As a more complicated scenario, the patient could present with flu or infection-like symptoms, such as cough, fever, chest pain, shortness of breath, in addition to any of the obvious signs of infection, like a wound that won't heal or a cyst. How would MRSA be diagnosed? MRSA presents as a skin infection. Confirmation testing is mostly lab-based. There's nothing to see that would readily identify an open wound as having MRSA present. It's a bacterial level that we have to identify. So things like wound cultures, nasal swabs, blood, urine, or pus can be sent to the laboratory for analysis. There are newer tests becoming more widely available that focus on DNA presence as opposed to bacterial growth. So as I said, identifying MRSA right now is mostly a laboratory process. You will have to culture something biological from the patient to confirm if they have MRSA and specifically which bacteria is present, as this will affect the treatment given. Simple swabs of fluids or wound cultures have been shown to generate enough results to equip medical staff properly to perform treatment given the antibiotics. The newer DNA-based tests give you a faster result, as in hours, over the traditional inoculation route with bacteria, which would have taken days to grow and identify the infection present. How we would treat MRSA is very simple. It's an either-or type of situation, and it's largely case-by-case dependent. The preferred route obviously would be the antibiotics, because the alternative procedure is called a lance and drain. The problem with lance and drain is that if you do not properly clean up or mitigate the transfer of bacteria, you could inadvertently give the patient another MRSA infection through improper sterilization practices and procedures during that exposure. So the traditional route of dealing with MRSA is proper antibiotics. Common ones like doxycycline or Bactrim have proven to be effective at eliminating a MRSA infection in the body, as they are outside of the psyllin family that the microbe has developed a resistance to. If the infection is more exposed, like an open wound on the skin or an inflamed boil-like wound, clinical staff have the option to lance and drain the wound. So as I discussed previously, lancing is a simple surgical procedure where you take a scalpel and carefully open up a wound, and draining is exactly what it sounds like. Clinical staff will then push the fluid out of the wound either through natural gravity forces or by mechanically draining it, applying pressure to the wound or boil with instruments or gloved hands like you were popping a pimple. But as we discussed, healthcare professionals are a little bit hesitant to go with the lance and drain right out of the gate because it does provide such a high risk of reinfection due to the nature of exposing that bacterium to other parts of the skin. MRSA over time have identified 3 long-term complications present. The most common occurrence of a long-term complication with MRSA is the higher risk of reinfection. The next most frequent is an impairment of the lymphatic muscle function. And the third most common is a diagnosis of cellulitis at the wound site. So that most frequent one, once again, being that high risk of reinfection, because MRSA lives on our skin, so any open wounds can present an avenue for the bacteria to enter the skin and trigger another infection. MRSA lives on our skin, it's always going to be there, but once you have had a MRSA infection on board, it seems to be a lot easier to acquire another one down the road. Recent studies and experiments have produced results giving us a better understanding of how active MRSA is in our bodies. The infection itself will clear in 30 days. The associated inflammation will clear in 60 days. However, the strange thing the experiments demonstrated is that MRSA affects muscles in our lymphatic system for 260 days. Essentially, a MRSA infection can simulate an immunocompromised position by weakening the lymphatic muscles responsible for transporting lymphatic fluid, which carries immune cells throughout the body, similar to the cardiovascular system. These lymphatic vessels manufacture the infection-fighting cells and then force the fluid to the parts of the body that need it through the contraction of lymphatic muscles. These muscles are the ones that are being impaired by MRSA infections. They are actively being damaged during the infection, which slows our immunoresponse time. The uptick in cellulitis diagnosis has also occurred in tandem with MRSA infections, citing that almost 30% of these cases of cellulitis reported can be attributed to MRSA. At this time, this concludes my presentation on MRSA. I hope you have learned several things like I have. This would normally be the portion where I would open up for a Q&A, but at this time, being virtual, we don't really have that. But I hope that this gives you a better broad knowledge understanding of methicillin-resistant Staphylococcus aureus and how to interact with it in our day-to-day lives. Thank you.